Hey guys, welcome back to my channel, The ENT Resident. Today, our topic of discussion is going to be about otitis media with effusion. You can also now purchase my notes. I have added links in the description. Okay, so let's get started with our topic. So, this is a very important topic, not only from your theory perspective, as well as when you are in your clinics, you'll see a lot of children come to you with maybe blocked sensation in the ear, or sometimes even fullness in the ear. And sometimes even the mother can come to you and complain that the child is not responding to them when they call the children, or like they are not attentive in the school, having some decreased performance in academics. In all of these cases, the disease that you should be thinking about is otitis media with effusion. So, now what is otitis media with effusion? So, this is basically a disease where there's accumulation of mucus within the middle ear behind an intact tympanic membrane and sometimes even the mastoid air cell system. It's important to know here that the tympanic membrane is intact over here. There is no disruption to the tympanic membrane, and we have accumulation of mucus within the middle ear. Now, this disease is known by a lot of other names as well. For example, it is also known as serous otitis media, secretory otitis media, non suppurative otitis media, and the commonest term, which is glue ear. So that's what otitis media with effusion is. And this happens to be actually the most common cause of acquired conductive hearing loss in children. Next, coming to the age group. So, the age group that it is most commonly seen in is about 3 to 8 years, within which a peak incidence is seen around 5 years of age. It is also important to know that around 1 to 2 years of age is also when sometimes the children suffer from otitis media with effusion. Although this is a disease that is very common in children, however, this can also occur in adults as well. Next, coming to season, when do we see an increased rise of this disease? In temperate countries, it has been seen that children seem to have otitis media with effusion more commonly in winter than in summer. And the reason behind that being because in winters we see an increased rise of upper respiratory tract infections. And during this time, also when children are coming in close contact with other children, maybe in their in their schools or in their daycares, they end up contracting more upper respiratory tract infection, and that leads to the development of otitis media with effusion. Now we'll talk about what is all the etiology behind this and what are the risk factors who are more predisposed to developing otitis media with effusion, after which we'll discuss the pathogenesis of the disease. So the most common important factor to remember here is any case, any cause that can lead to eustachian tube dysfunction can lead to the development of otitis media with effusion. Now, possible causes in children are adenoid hyperplasia. So, a lot of children you'll see they'll have coexisting adenoid hypertrophy. If you perform a X-ray nasopharynx lateral view on these cases, you'll be seeing enlarged adenoids. So, in a lot of times, you'll be seeing that these cases they do not get resolved with medical management because the underlying causating factor would be the adenoid hypertrophy. So, in those cases, you would have to perform surgery where you do an adenoidectomy to remove the adenoids, and then eventually you'll see that the patients start resolving by itself. So, this is one of the more important causes. Other than this, there can be chronic rhinosinusitis. There can even be chronic tonsillitis. So, what happens if there is chronic tonsillitis is the enlarged tonsils they end up obstructing the movement of the soft palate mechanically, and this starts interfering with the physiological opening of the eustachian tube. So sometimes you may even need to perform tonsillectomy in unresolving otitis media cases if this is the causative factor. Other than this, there could be even benign and malignant tumors of nasopharynx. Now, this is more commonly seen in adults. So, if an adult presents to you with unilateral serous otitis media, you must think that the cause is not just limited to the ear. Rather, you should also perform a nasal endoscopy and see if there is any tumor in the nasopharynx. Another causative factor is children with craniofacial abnormalities, especially if there is palatal defects like cleft palate or palatal paralysis. In these cases, because of the palatal muscles being not strong enough, that it leads to eustachian tube dysfunction. And I'll talk about in a little bit under pathogenesis how eustachian tube dysfunction leads to the development of otitis media with effusion. Second risk factor is allergy. So it has been seen that seasonal or perennial allergy to certain inhalants like maybe dust, pollen, can be responsible for causing otitis media with effusion in children. Third reason is unresolved acute otitis media. Now, sometimes in acute otitis media cases, if it has not been treated completely, if inadequate antibiotic therapy is present in these cases, it can be in terms of dose or duration or frequency of the antibiotics being used. So, whenever there is inadequate antibiotic therapy in acute otitis media, it can result in inactivating the infection, but it does not resolve the infection completely. So even though the acute symptoms of pain discharge will resolve, but it will not remove the infection completely. So there will end up being a residual low grade infection at all times. Now, this low grade infection will act as a stimulus for the mucosa to secrete more fluid in the middle ear, and that will lead to the development of otitis media with effusion in these cases. And all the risk factors of acute otitis media that we know of, like prematurity or frequent upper respiratory tract infection, these will also act as risk factor in this case. Next is viral infection. Now, certain adenovirus and rhinovirus of the upper respiratory tract, they can end up invading the middle ear mucosa and stimulate it to increase the secretory activity of the middle ear mucosa, leading to the development of otitis media with effusion. And last factor, etiological factor over here is gastroesophageal reflux. Now, gastroesophageal reflux is very common in children. It occurs in about two-thirds of infants at 4 months of age. So during the time you're swallowing, because of the gastroesophageal reflux, the fluid can travel from the nasopharynx via the eustachian tube and enter into the middle ear. And mucosal damage can happen because of the proteolytic activity of pepsin in this reflux. And these are all the risk factors or etiological factors behind otitis media with effusion. Now that we know all of these causative factors, let's try to understand what is the pathogenesis of the disease. So, the first important factor that I have mentioned is eustachian tube dysfunction. This is the most important theory that we need to know. So, if you look over here, this is the eustachian tube and it connects to the nasopharynx over here. And the eustachian tube is connecting the nasopharynx with the middle ear over here. So, whenever there's any cause of eustachian tube dysfunction, this passage that you're seeing, it kind of gets blocked. So, the eustachian tube, one of the most important functions of eustachian tube is aeration of the middle ear as well as drainage of secretion from the middle ear. So, when the eustachian tube gets blocked, it is not able to aerate the middle ear properly and it is also not able to drain out the secretions from the middle ear. All of this combined leads to the development of negative pressure in the middle ear. Now, as the negative pressure in the middle ear builds up, it leads to more fluid accumulation over here. Now, because the fluid is not able to drain out, this continues happening, leading to more chronic inflammation. Initially, when the fluid accumulation starts, it's very thin and serous, but later, as time passes and as more chronic inflammation goes on, it becomes mucoid or rather glue like. This is where this gets the term of glue ear. So, this is the most common theory as to how otitis media with effusion develops. Other than this, we have more theories. One is the ascending infection theory. So, if there is a subclinical infection going on, maybe involving the sinuses or the nasal cavity, if you are having chronic rhinosinusitis, or if a patient is suffering from reflux of nasopharyngeal secretions, this, because the reflux reaches up to the nasopharynx, through the eustachian tube, these bacteria and toxin can get they can get a passage to reach the middle ear through this eustachian tube. Now, this will lead to the development of either mild infection or sometimes even bacterial biofilm formation occurs over here. As a result of this, there is a persistent low grade inflammation, and this leads to the development of mucosal edema and effusion production. So, this is our second theory, which is basically saying that any kind of ascending infection, either from the nasopharynx or a reflux of secretions, can enter the middle ear via the eustachian tube, leading to the development of otitis media with effusion. And our third theory is an inflammatory theory where exposure to any kind of allergens or irritants can lead to inflammation of the nasopharynx and eustachian tube. And this inflammation will lead to the development of mucosal edema and eustachian tube obstruction, and ultimately leading to the fluid accumulation in the middle ear. So, these are our three theories to describe the pathogenesis behind otitis media with effusion. Now, next, let's talk about what are the pathological changes that we will be seeing here. So, if you look at the middle ear mucosa, we'll be seeing that the middle ear mucosa becomes thickened and edematous. And the effusion that is collecting in the middle ear actually can vary from serous to mucoid and even eventually become mucopurulent. Looking at the histological or rather the microscopic findings, the flat cuboidal epithelium in the middle ear and mastoid, they start to get replaced by thicker pseudostratified mucus secreting epithelium with varying degrees of cilia. And a very important factor that we'll see here is goblet cell hyperplasia. So the goblet cells are responsible for secreting this mucus. So we'll see an hyperplasia involving the goblet cells. And the ciliary lining, which is usually normally present, it becomes less efficient at moving the secretions into the nasopharynx than in normal cases. And next is submucosa. So the submucosa will again be edematous and it will be inflamed with dilated blood vessels, and we'll see an increased number of macrophages, plasma cells, and lymphocytes. And lastly, the effusion that collects in the middle ear, it is predominantly comprising of glycoprotein mucin. And this also contains secretory immunoglobulin A, lysozyme, interleukins, and other inflammatory cytokines. So that's about the histopathology of the changes that is occurring within the middle ear in case of otitis media with effusion. Next, let's look at the microbiology of this. So, even though this is not an infective disorder, in certain cases we will be finding numerous bacteria associated with this disease. And these bacteria can often form biofilms, and these biofilms aid in the low grade infection continuing on. And the most common bacteria involved here is Haemophilus influenzae. The second most common bacteria involved is Streptococcus pneumoniae, and other than this, we also see Moraxella catarrhalis in such cases. Next, how do we classify otitis media with effusion? So, based on duration, we can classify it into three types: acute, subacute, and chronic otitis media. Now, acute otitis media with effusion, the duration is less than 3 weeks. These cases usually follow an acute episode of acute otitis media, and they are more likely to resolve spontaneously without any medical management. Second type is subacute otitis media, where the duration is between 3 weeks to 3 months. Here, we see persistent effusion after infection or eustachian tube dysfunction. And some cases may resolve without any intervention, but most cases will require medical management over here. And the third type is chronic otitis media with effusion, where the duration is more than 3 months. Here, long standing effusion leads to a lot of mucosal changes, and these cases usually do not respond to medical management, here we need to do surgical management to treat the disease. And these cases often end up with a lot of complications as a result of the disease being persistent. Next, let's talk about how will a patient with otitis media with effusion present to you with. So the most common symptom, the most important presenting symptom here is hearing loss. Sometimes this can actually be the only symptom as well. This hearing loss is usually insidious in onset and rarely exceeds 40 decibels. So we see a very mild conductive hearing loss over here. Mostly it is conductive, and sometimes we may find sensory neural hearing loss as well if there is toxin diffusion happening through the round window into the inner ear, sorry. But mostly we'll see a conductive hearing loss. And commonly, the complaint of the patient would be usually the mother would come to you and they'll say that their child is not responding to their calls. And sometimes you can see also complaints of the child listening to the television, either very standing close to the TV, or sometimes they increase the volume way too much. And also complaints of less attention being paid in school. This will lead to decreased scholastic performance in school. So the main disease over here that you would have to consider is otitis media with effusion. So hearing loss is our most common symptom. Other than this, they can also come to you with blocked ear sensation or sometimes even complaining of heaviness in the ears. But it is important to know that usually there is no pain or fever, and this is what helps to distinguish it from acute otitis media. Very rarely, you may see some mild earache because of the collection of mucus within the middle ear. Other than this, the patient can also have poor speech and language development, difficulties with balance, inattention, and behavioral problems at school. These are all the symptoms that you'll be seeing. Now, when you examine the patient, what will we see? So, when we do an otoscopy, we'll be seeing that the tympanic membrane appears dull and opaque, and it can have an amber or yellow colored. It loses the light reflex. There can be varying degrees of retraction seen in the pars tensa. Sometimes, because of the collection, it may also appear full or slightly bulging. A very typical appearance is what we are seeing in the image over here. You can see the appearance of air fluid level and a lot of bubbles behind the tympanic membrane. It is important to note that the tympanic membrane has to be intact over here. So, this is a very, very characteristic appearance of otitis media with effusion. And when you perform a pneumatic otoscopy, you will see that there is reduced mobility of the tympanic membrane. So, all of these are very important findings to note to make the diagnosis of otitis media with effusion. And otherwise, if you examine the nose, if there is symptoms of sinusitis, you will be seeing those features in them. And if you look at the nasopharynx, you may find adenoid hypertrophy in children if that is the causative factor. And when you perform tuning fork tests, we will be seeing Rini negative and Weber lateralized to the diseased ear, which is directing towards a conductive hearing loss. And the hearing loss is usually very little, it is usually less than 40 decibel, rarely exceeds 40 decibel. So this is how our patient will present to you with. Now, how will we investigate the disease? Investigations are not that important over here, rarely done. This is mostly a clinical diagnosis, but there are some investigations that can be done. First of all, is pure tone audiometry, which will show a conductive hearing loss of less than 40 decibel. Sometimes, as I mentioned earlier, you may also see a sensory neural hearing loss, which can happen because of the passage of toxins from the middle to ear to the inner ear via the round window. When you do impedance audiometry, you will be finding type B audiogram. And it'll the type B audiogram, if we look over here, this is what a type B audiogram looks like. This is a flat curve. So this is a very typical investigation that will confirm our diagnosis over here. Usually we don't need any other investigation like X-ray mastoid, which will show a clouding of air cells. X-ray nasopharynx is done if we are suspecting enlarged adenoid. In that case, we have to perform an adenoidectomy to treat the disease. And a CT or MRI scan is usually not done, but if we are suspecting any nasopharyngeal tumor, in that case, we can perform a CT scan or an MRI. So that's about the investigations. Now let's talk about how will we treat the disease. So first of all, we have to observe because most cases over here resolve spontaneously, and we'll also have to counsel the patient as well as their parents that what are the features of this disease, how does it usually present, how does it resolve, why do we expect it to resolve spontaneously. Next, moving on to medical management. If the disease does not resolve spontaneously, we can use nasal decongestants and saline irrigation. This will help in relieving the edema of the eustachian tube and drain out the secretions via the eustachian tube. Second is if there is any allergy suspected, we can use anti-allergic measures like antihistamines or sometimes even topical steroids. But topical steroids is not commonly used. More commonly, antihistamines are given to treat allergy. Antibiotics have a very limited role over here. It is only used in cases of upper respiratory tract infections or if there is an unresolved acute otitis media. Very important aspect of treatment is to perform exercises that will help in ventilating the middle ear. Why? Because this will ventilate the middle ear and promote more drainage of the secretions that is collecting in the middle ear. How can we do that? By performing Valsalva maneuver multiple times in the day, or sometimes even polycerization or eustachian tube catheterization may be required. Even chewing gums can help in opening of the eustachian tube and increase the ventilation of the middle ear. So these are all our medical management strategies. Now, in cases where medical management has not worked, especially in chronic otitis media cases, we have to resort to surgical management. Now, what are our options over here? Our first option is to perform a myringotomy and aspiration of fluid. What we do here is we make an incision in the tympanic membrane and then we aspirate the fluid with suction. And the most common site for this is the antero-inferior quadrant. We should definitely not incise in the posterior-superior quadrant because if we remember the anatomy over here, in the posterior-superior quadrant, we have all the ossicles. So we risk injury to the ossicles if we give an incision in the posterior superior quadrant. The best quadrant to give an incision in is the antero inferior quadrant. Now there's something called beer can principle. What happens here is, say you have given an antero inferior quadrant incision, but you're still not being able to drain out all the fluid. This happens usually if there is thick fluid in the middle ear. In these cases, we may need to give a counter incision in the antero superior quadrant, as you can see over here. And this will allow the air to pass into the middle ear and facilitate the fluid removal through the other incision. So that is the beer can principle. Now, say even after performing myringotomy and aspirating the fluid and combining it with other medical measures, if it still comes back, in that case, the next surgical management is to insert a grome into the middle ear. So, grome, also known as the ventilation tube, is inserted. If you see in the image over here, this is the grome insertion, and this will continue to provide aeration of the middle ear. It is usually left in place for weeks to months, or sometimes it can even get spontaneously extruded. So that is about grome insertion. Lastly, if there is any other cause, like for example, adenoid hypertrophy or chronic tonsillitis, in those cases we may need to perform adenoidectomy or tonsillectomy to provide cure to this disease. So these are all our management of, this is how we'll manage a case of otitis media with effusion. The prognosis of these patients are very good. Usually, most of the cases resolve spontaneously and hearing completely recovers. Lastly, let's talk about what is the complications of a long-standing otitis media with effusion. So the first complication is like the atrophic tympanic membrane and atelectasis of middle ear. So when there's been a chronic negative middle ear pressure over a long period of time, it leads to the dissolution of the fibrous layer of the tympanic membrane. The tympanic membrane becomes very thin and atrophic and it starts retracting into the middle ear. The first image over here, you can see how the tympanic membrane is very thin and atrophic, especially over here in this quadrant. Second complication is ossicular necrosis. The most common bone to be involved here is the long process of incus. Sometimes even the stapes suprastructure can get necrosed. If there is ossicular necrosis, in those cases, the hearing loss will exceed 50 decibel. But otherwise, normally we do not see a hearing loss more than 40 decibel. Next complication is formation of retraction pocket. As we saw here that the thin atrophic tympanic membrane can actually start to get invaginated inside the middle ear due to the chronic negative middle ear pressure, and this will form retraction pockets and eventually form cholesteatoma. So if you see the second image over here, here we are seeing a attic retraction pocket. This will eventually predispose to the development of cholesteatoma formation. Next complication is a cholesterol granuloma, which can form due to stasis of secretion in the middle ear and mastoid. And lastly, if untreated or even if there is long standing chronic otitis media which is not resolving, it can lead to permanent hearing impairment. So that's all about otitis media with effusion. If you have any further questions on this, please note them down in the comment section and I'll get back to you. Thank you.